it in the viewer? There you go. Okay.
There we go. I'll swap display.
We have Dr. Robert Pack from Eastern Tennessee State University. I'm going to do one more thing here. Sorry about that. There we go. Okay. We can see you now.
Oh, great. Hi, good afternoon. How are you?
His or mine? Oh, okay.
Can you hear me okay?
Yes, we can hear you. There we go. We welcome Dr. Robert Pack from Eastern Tennessee State University, who's going to be talking about prescription drug abuse prevention and research. Thanks, Dr. Pack.
Hey, great. Thanks for having me and requesting the presentation. I will do my best to stay on target for time. I am amazed that you were so close.
Okay.
Given your impressive schedule that you had today. So thanks for inviting me. I want to tell you a little bit about our research today, what we're doing with the DIDARP funds, and I'll talk a little bit about our infrastructure as well as our activities. To start out, though, I think it's probably important to sort of frame the issue of prescription drug abuse. I know I think I'm one of the few talks today on the topic, and most folks, when they think about prescription drug abuse, they're thinking about OxyContin or something to that effect. The reality is, in Tennessee, our biggest problem is really with hydrocodone, and followed by Xanax, which is alprazolam, as you can see, the second largest wedge in the pie. These are drugs that were reported to our Controlled Substances Monitoring Database in Tennessee, for which we have mandated use for new prescriptions. So we have a hydrocodone, alprazolam, oxycodone problem, as well as these other tranquilizers and other painkillers and or medically assisted therapy options like buprenorphine or morphine, methadone style products. So it turns out that the U.S. Consumes twice as many opioids per capita than the next closest nation. We're the #1 consumers in the world. We actually, in Tennessee, we happen to be the #2 state in the #1 country. We're just behind Alabama, according to the CDC's data that they released last year. And in Tennessee, we are far and away the worst part of the state. East Tennessee, which is right up against the mountains and Central Appalachian Range, we are far and away the #1 prescribing area for opioids. And when there are a lot of opioids that are around and in cabinets, there are a lot of opioids for misuse, and that's indeed what has happened. Most folks are aware of the painkiller sales and increasing treatment admissions, and especially aware of the increase in overdose deaths. There's been a lot made about this in the news, a lot of celebrities and so on. The lived reality here is, in our relatively small town, it's uncommon to pick up a newspaper and not find, a story about another opioid-related crime, overdose death, or in some other case, some sort of other tragedy related to this particular problem. We also have in Tennessee been one of a group of 4 states that have really been the highest number of states with babies that are born dependent on prescription narcotics and or medically assisted therapy replacement drugs. We actually have mandated reporting of neonatal abstinence syndrome, as this is known, and it's been increasing dramatically over and above the previous year, with the sole exception of this year. We're presently on target with our numbers from last year, so hopefully we're beginning to turn down the problem of neonatal abstinence syndrome in the state. But this is a really tragic outcome of the opioid abuse problem. And of course, concomitant increases in crime. We have a doubling of drug crimes in the past 7 or 8 years, and that's been a direct result of the prescription narcotic problem. As most people are now aware, heroin is going to backfill the prescription narcotic void whenever we get a sufficient handle on prescribing practices to really turn it down. Both prescribing practices as well as the Controlled Substance Monitoring Database are beginning to dry up the available narcotic opioids that are on the street, but this heroin problem is going to quickly replace it, as we're already seeing. Most folks are now aware of this. It's a complicated problem. We use this slide to really help break down what's going on with respect to the problem. If you consider the continuum from non-use to abuse or to death, really there are levels of activities that you can do to intervene on that continuum all along it. For example, on the left side, you can do much more primary prevention activities in this area, as well as D&I, dissemination and implementation of effective prevention programs. A lot of folks really focus on things like trying to turn down the volume of pills that are out there. It turns out that that's really most relevant when folks have slipped past dependence into addiction. So really there are a multitude of different evidence-based approaches we can bring to bear on the problem, and we really need to be doing that at an organized and consistently thoughtful approach to tackle the problem on multiple different levels. It's not just one of those blue boxes that's going to work. So to begin to combat the problem, we formed the working group, the Prescription Drug Abuse Working Group, in 2012. We now have 25 or 30 people that attend every month. We've met every month since 2012, and we have a highly interprofessional group. It's really a focus on research. It's a community outreach and community-based participatory type of group with CBPR style objectives. We do a lot of service activities and education, and we're really seeking a lot of new grant funds for different projects, which is consistent with the DIDARP, as you'll see in a few moments. There are now 100 plus members of the working group, some of which are from public health, but also we have psychology, pharmacy, other folks, and medicine, and so on. A lot of community partners. We actually meet off campus every other month at a different site, so we can begin to deepen our community ties. It's a very healthy working environment that has led to a lot of different products, one of which is the DIDARP project or program. We've also had some success in obtaining funds for neonatal absence syndrome. A recent award for prescription stimulant misuse. We've developed a coalition out of this activity, as well as deep connections to government with respect to the local workforce promotion programs and workforce employee assistance programs and things of that nature. The red circles are really proposals that have come out of the working group that weren't funded. We did propose a research center, prevention research center. It wasn't funded, as well as a stimulant misuse project for college students. It wasn't funded, but we're going to recycle those ideas and seek other opportunities as we go forward. We do have a couple of projects in the wings right now. Now, what happens in the working group is, we form core teams for different proposals, and then we make connections with our partners through that working group. We've done tons and tons of CE events and public presentations. We've also been publishing our work, and one of the things I really like is our internal interprofessional prescription drug abuse grand rounds, and then the journal club that goes along with that. That's led to a lot of on-campus excitement about the issue, which is one of our objectives, as you'll see in a moment. One of the objectives for the DIDARP grant in general. This has also led, this connection to the community has also led to a really nice working relationship with our elected officials that is yielding some pretty amazing fruit at this point. So a couple of other things, you know, we've been, by virtue of being out and speaking a lot about the problem in the region, we wound up getting a fair amount of media coverage, including we had the cover of USA Today once for Dr. Lloyd was on that, as well as a live chat with Huffington Post and so on. So we do a lot of print and radio as well. So bringing some notoriety to the college and the university from those activities. Of course, I mentioned we were getting out into the peer-reviewed literature most recently, and AJPH, really excited to have this publication that was basically DIDARP, the first DIDARP-specific paper for one of our first studies that was a briefer study at the beginning of the 5-year award, was just recently published in AJPH in July. So our first aim for the DIDARP overall program was to provide leadership and support within the Academic Health Science Center to increase the number of successful prescription drug abuse researchers from disadvantaged backgrounds. So a note about ETSU. East Tennessee State University is one of the smallest research universities that is an Academic Health Science Center that's a member of the AAHC. That's also at a comprehensive regional institution. So we're actually a fairly unusual institution, and we wound up having a highly interprofessional focus. We're fairly small. We don't do that much funded research, although we're working on that at this point. And so it's a really interesting place to work and to get projects moving because there's a lot of eagerness to really grow scholarship here. So we also are a highly accessible institution, and we have a number of students. About 40% of our student body are Pell eligible. Receive Pell grants. So we have about 52% that are first-generation college students. So we have a really interesting student body here. Our second aim is to provide mentored training opportunities for undergrads, grad, and professional students, and postgraduate fellows. And junior faculty members, which we've been doing. We've been evaluating them based on these National Postdoctoral Association core standards. It's a pretty interesting product there if you're interested in that sort of evaluation. We do have our inaugural pharmacy fellowship program, which is really a great program, and we just had a doctoral dissertation hosted out of the DIDARP work. Our aim is to ultimately develop greater infrastructure here that supports the successful conduction of prescription drug abuse research and then attracts further extramural funding for that same kind of research. We do have a vision for a center and even a plan in place for how to make that happen. And that's ultimately, it's one of our ultimate goals here. Fourth aim is to advance the field of prescription drug abuse research using institutional resources and the DIDARP studies. We've strengthened our connection to the government doing this. We've put forward a lot of different resources out into the community, as well as loaned a lot of expertise to local officials. Our research efforts are aimed at healthcare provider and patient communication to prevent prescription drug abuse and misuse, as well as an analysis of a controlled substance donation effort via DEA-Sanctioned drug take-back studies, events, and drug donation boxes in Central Appalachia. That Project 3 was an abbreviated project, really a 1.5-year study or so, and that's the one that was recently published in AJPH. Projects 1 and 2 are ongoing. Project 1 is actually completed analysis of the focus group discussions and transcripts. There's a manuscript under development right now. Next step is to begin the quantitative studies, and we're putting that contract in place right now. In fact, met with that person this week. Project 2, we've completed those surveys as well. I'm sorry, the qualitative side of that on the front end, and we're beginning the creation and validation of the quantitative instrument, which is all focused on healthcare, provider, and patient communication. And then Project 3, as I mentioned, is this controlled substance take-back event. We had a lot of volunteers that helped us basically quantify the donations, and we found that out of the thousands and thousands of pills that pounds of pills rather that we took in, about 8% of them were controlled substances. So there's a lot of pills that are out of the cabinets that won't be misused now thanks to that effort. We got a lot of media coverage, as you might imagine. I mentioned our regional connections to government and so on. Our prescription drug abuse and misuse website is up and running and gets a fair amount of traffic. And finally, just a little bit over time, I apologize here, is our team. It's a fantastic team. They're highly productive, very efficient. So I would be delighted to answer any questions if you have them.
Thank you, Dr. Pack.
I'm out of time.
Thank you, Dr. Pack. Great. Any questions for either anybody here or other remote sites? Okay, great. Thank you so much.
Yeah, well, thank you. Let's see here.
You'll pass the ball back to me, or?
Okay.
There we go. You got it?
So I'm going to say stop sharing here.
Okay.
And are you back in control?
Okay. Great. Dr. Pang? And quarter button.